a lot of this stuff we've kind of already covered, so it should go pretty quickly. So when we talk about OSA, do we want to do in-lab or HST stuff? And so how do we figure out what needs to happen if you think somebody's got sleep apnea? If you just ask them based on a history, about 50% of the time you're right in terms of diagnosing that they have sleep apnea. Sometimes it's hard to guess whether they've got it severe, moderate, or mild, but you can usually go, I think, but we still miss people. We miss people who maybe are mild, somebody who looks like Anne, and you wouldn't go, okay, you snore, I think you're fine, but actually she has sleep apnea. Pulse oximetry is about 60% accurate in diagnosing sleep apnea. The problem we have, particularly at altitude, is that we have an increased rate of central sleep apnea, which is when you just stop breathing. It has to do with respiratory drive, blood chemistry, and oxygenation. So people who are at risk for central sleep apnea or Cheyne-Stokes respiration are people who've got atrial fibrillation, people who've got pulmonary disease, other cardiac conditions. So if you just look at a pulse oximeter, you can go, oh, well, you know, they're desaturating. But if you put somebody who's got central sleep apnea on CPAP, that's not appropriate treatment. Sometimes it'll make it won't improve it, sometimes it makes it worse. And oral appliance therapy is inappropriate for somebody who's got central sleep apnea as well. The other problem with pulse oximetry is sometimes you have somebody who doesn't have significant desaturations but does have significant sleep disruption due to mild hypopneas, where they're not having big desaturations but they are having disrupted sleep. The home sleep apnea test that we use is clinically valid because of the way we do it. It's about 90% effective in diagnosing sleep apnea. And we can tell the difference between central and obstructive sleep apnea with the testing that we use. The in-lab test is the gold standard for diagnosing obstructive sleep apnea. It is 100%. You can also diagnose periodic limb movements. You can diagnose narcolepsy. The home sleep apnea tests are not appropriate for children, so usually we say they need to be 18 or older for it to be appropriate. So that's another place where the home sleep apnea test doesn't fit everybody. When we're talking about the OSA treatments, the PAP therapy is still considered the gold standard because it is very effective, treats most people. It gets a little trickier at altitude, but still it has a really high improvements, so you can take somebody who's severe and get them to normal. Sometimes you can't get them completely to normal, but pretty close depending on if they've got other conditions going on. Oral appliance therapy is 70% effective in treating sleep apnea. Again, it's kind of like that surgery thing when they talk about effectiveness, that to be effective it has to at least improve the apnea-hypopnea index, or the number of times you have complete or partial airway obstructions per hour, in half. So that's why it's a first-line treatment for somebody who's got sleep apnea that's mild or moderate, but not a first-line treatment for somebody with severe sleep apnea, where they stop breathing 40 times an hour. If you cut that in half, they're still in the mild to moderate category and still will have some sleepiness. But one of the things I learned in treating my husband is it's better to do something than to do nothing. He couldn't tolerate CPAP for a long time. We started with an oral appliance, and that got him on the road to getting better. And now he does use CPAP nightly. The surgeries we talked about a little bit, they kind of have moved away from those UPPs. Tonsillectomies for people who've got mild sleep apnea and big tonsils. The bariatric surgery is a good option for people who have a significant amount of weight to lose. The positional devices can be highly effective for people who've got positional sleep apnea. Find ways to keep them off their back and they can sleep fine and not need anything else. For many people, that's trickier to do than you think. In the sleep lab, we'd have people all the time who'd say, I never sleep on my back. And you'd let them not sleep on their back, and then they would spontaneously flip onto their back and have terrible sleep apnea, and it would be too late in the night to do anything. It's like, oh, you're gonna have to come back. And then weight loss. Insomnia, the only time we test for insomnia is to rule out other sleep disorders. We're not going to test to see if they've got a cognitive issue. That it's just not going to be useful. Like I used to tell patients, who'd say, well, can I take my sleep aid for a sleep study? It's like, absolutely, because we're looking for sleep apnea. You won't have it if you're awake all night. So we need you to be asleep. So that's the only time we do that. So the first thing we do with insomnia is make sure there isn't another sleep disorder, and if there is, to treat it. Improve the sleep hygiene. those environmental things, the behaviors that we do, address environmental factors, cognitive behavior therapy, which actually has improved long-term efficacy versus medications. And then over-the-counter medications for insomnia. If somebody uses Benadryl, it's not addictive. It's fine to use, and for somebody who's got other like sinus issues, sometimes it can improve the snoring. They don't have sleep apnea. It helps them fall asleep. It's fine. You want to kind of be careful with some people, I think you know this, who take Tylenol PM. If you take too much Tylenol, especially if you do drink alcohol, it can have some adverse effects on the liver. People who overuse NSAIDs also are at risk for heart problems. So you just have to be careful. And if they have pain and they're sleepy, then okay, with good guidance, you can take an Advil PM or something like that. If on the other hand, your only issue is sleepiness, they make the NyQuil Z's, or you can just take straight Benadryl without having to worry about those other side effects. We discussed that PLMD does need an in-lab diagnosis. The problem with RLS and PLMD treatment is it's tricky. Since it is progressive and does get worse over time, it makes it harder to find something that's going to last and be effective. What you can try to do is first of all figure out if they have low ferritin levels, and only if they have low ferritin levels, you can give them supplemental iron. It does sometimes improve the symptoms. However, giving somebody supplemental iron if their ferritin levels are not low is not a good idea, because it will stay in the liver and have significant long-term health problems. Sometimes just application of heat or ice just to kind of tone down those symptoms can help, as well as some massages and lotions. Everybody's going to be different. Encourage patients to try those kinds of things to see if they get some improvement. There are some additional over-the-counter treatments. Tonic water has quinine in it, and sometimes that can help calm it down a little bit. Sometimes people have some improvement with magnesium. Again, you just got to be careful that you're doing that under the advice of a physician who's monitoring your levels. And then there are also prescription medications. I used to use L-Dopa as the treatment of choice. The problem with it is that it didn't always last long term, and over time people would start having a tolerance. It wouldn't be as effective, and there are other problems, side effects of using L-Dopa. Probably the most commonly prescribed medication now is the Requip, which does have some significant improvement for some patients. Another option that they used to use years ago and they still occasionally use is something like Trazodone or Klonopin, which are tranquilizers, to allow patients to sleep through the arousal that they would have after they would move their legs. Another one that can sometimes help, which seems odd, is cognitive behavioral therapy, because it helps patients, again, to not have that anxiety about, oh my God, are my legs going to be driving me crazy tonight? And if they can find a way to focus their thoughts elsewhere, it can help them to at least be able to relax enough to go to sleep. The parasomnias, again, I think we talked about this earlier about the age. If you've got a child or adolescent who's sleepwalking, they're probably going to outgrow it. You really want to focus on the story, and you want to focus on safety issues. Make sure that they don't have access to the keys, that there aren't breakable things in the sleeping environment or nearby. That poor gentleman that we saw the video of, the fact that he had that step down into his living room that he would jump off of all the time, that would be one of those safety issues, just to make sure that people who are doing these kinds of things are okay. There was a woman who used to, who smoked in her sleep, and you know, people with these disorders are smart. So if her boyfriend would hide them or tuck them away where she could see it while she was awake, it didn't matter where she'd climb the bookcase to pull them down. So she had to leave the room while he hid her cigarettes before she went to bed. So she didn't know where they were. So her conscious mind didn't know, so that when she was asleep, her unconscious mind couldn't go find them. So things like that, or finding ways to make sure people don't like cook or things like that, that the utensils are secured. Again, you want to make sure you treat any coexisting conditions. Make sure it's not sleep apnea that's kicking you into that, or that you're getting adequate sleep. Make sure that you're not depriving yourself of sleep, because I know that I do confusional arousals. I know if I get sleep deprived and stressed enough, I'm more likely to do them. Or if I travel and do time zones and it affects my sleep, I may answer a phone that's not ringing in my room. Or, so I make sure I lock my doors. Sometimes you can take a mild hypnotic if you travel and you do those kinds of things to prevent you from doing dangerous behaviors when you're traveling. A sleep specialist or neurologist can help with that as well. Particularly if you're not sure if someone's having seizures at night. There are some people who have nocturnal seizures that disrupt their sleep that are unrelated to other conditions, and medication can help that. Methods to wake a patient from deep sleep. Usually you're not going to do that with adults so much, but it can be helpful in children. If you're awake and you know that about 70 minutes into sleep they might be moving into REM and they might hit that twilight zone area, if you can set an alarm or do something to wake them up so that they lighten their sleep a little bit, it can keep them from going into sleep terrors or those things that are so disturbing to everybody's sleep. And just understand it's a wiring issue. My mom was a sleep eater without medication. She just worked the night shift. When she moved off the night shift, she stopped sleep eating. And the lasagna would last longer. Sleep phase disorder. We talked about the importance of finding out if it's insomnia or if it's a sleep phase disorder. Sleep logs are the easiest way to track that. Give somebody a thing that says, what time did you go to bed? How long did it take you to fall asleep? How long did you sleep? When did you get up? How many times did you wake up? And that helps them kind of track, and it gives them feedback as well in terms of how much sleep am I really getting? And then you can look at that data and go, oh, I'm getting 8 hours of sleep. It's not insomnia, it's something else. Again, make sure there's not a coexisting sleep disorder. That evening light therapy, it doesn't have to be a lot. And when we start moving into the darker times, there are lights you can get that will help you do that beyond your handheld devices, that can give you that right spectrum that's going to give you an opportunity to move that melatonin secretion and help you fall asleep later for the elderly folks who tend to be advanced, or earlier for the teens. Especially for the teenagers, one of the things that sometimes parents are reluctant to do is get them up early. Same thing is true with insomnia sometimes. We can't always affect when we fall asleep. We can't control that, but we can usually control when we get up. So that's one of the ways that you can attack those issues and say, okay, I know you're up till 2, but I can't let you sleep till 10 if you're going to then be up till 3 tomorrow night. So you have to get up, you have to get busy. Let's get you outside, rake some leaves, or do something to help reset that clock. Having a consistent sleep schedule really helps, especially for people who tend to lose that tracking. Most of us are pretty good. You miss a few nights, you can sleep in and you're okay. Some people get really sensitive to that and need to have a consistent sleep schedule. I had a patient who used to call me up at night and gave her all these sleep tips, and she called me back 6 months later and she goes, yeah, no, they worked for a while and then they stopped working. And I said, did you keep doing the behaviors? Oh, no, I didn't. I went back to what I did before. I'm like, you have to be consistent. That's just how it is. I need adequate sleep or I'm going to do crazy stuff in my sleep. You need to get up at the same time every day. Narcolepsy, as we discussed, it needs an in-lab diagnosis. It's a very specific test. We also test when we do that for drugs of abuse that can have effect on sleep. So typically we do a urinalysis to make sure that there's not cannabis or hypnotics or other things that can affect the sleep cycle in the system. And then when we treat it, again, treat the coexisting sleep disorders. Scheduled naps can be very helpful. Stimulant medication is typically Adderall, Ritalin, or Nuvigil. They do have to be careful with driving. While most narcoleptics are not at the level that we saw with D. Dowd, sleep attacks are very serious, and if you cannot control your sleepiness, you have to be careful. The gentleman that I spoke about who fell asleep making sandwiches, he lived in Boston, and so his technique was, he was originally from Africa, and he would just find somebody who looked kind on the T, and he would say, I'm not sure where my stop is. And then he would sit down and he'd fall asleep. And then when the stop came, then that person would say, oh, dude, it's your stop. And he would, oh, okay. That was how he coped. because he could not function and get where he needed to go otherwise, and he couldn't afford to take a taxi cab everywhere. So he knew that he was not safe to drive. And then understand it's a chemical wiring issue. It's that they've recently figured out it's hypocretin in the hypothalamus that is insufficient, and that's why they have this. Back in the day when I went to school, we talked about the reticular activating system, which is kind of the wiring back here that helps us go to sleep. That's all linked in there as well. All right, so you ready for quiz C? Also, only a page and a half, so not too long. Number 1, obstructive sleep apnea can be diagnosed by in-lab study, home sleep test, pulse oximetry, patient history. The answer is all of them. However, they are not all equally effective. What is the best therapy for severe OSA? PAP therapy, correct. True or false, oral appliance therapy is only appropriate for patients who fail PAP therapy? False. False. True or false, insomnia must be diagnosed with an in-lab study?
False.
False. Insomnia is about the story. Other conditions in lab. Insomnia patients who complain of dry mouth, morning headaches, and frequent trips to the bathroom at night may have OSA, RLS, parasomnias, none of the above. OSA, correct. Insomnia patients may be treated with all of the following except prescription meds, cognitive behavioral therapy, counseling about sleep hygiene, set an alarm to wake them from deep sleep. D. Don't wake them up. Please don't wake them up. Periodic limb movement disorder is diagnosed by in-lab study, HST, sleep logs, or all of the above. A, an in-lab study. All of the following features of RLS PLMD are true except it has minimal impact on sleep quality, movement relieves the sensations of tingling, tightening, it worsens with age, and treatment is challenging. Oh wait, you're right, A. You're right. I'm a sleep expert. True or false? Nightmares and night terrors are the same thing. False. What's the difference?
The nightmares are like bad dreams, and night terrors, they wake up and they often don't even remember what they did.
Perfect, very good. That is exactly right. All of the following are treatment options for parasomnias except diagnosis and treatment of other sleep disorders, light therapy, limit use of hypnotic medications, set an alarm to wake patient from deep sleep. Light therapy, that's right. A first-line method for determining if a patient has a sleep phase disorder is sleep logs, correct. Light therapy for delayed sleep phase should be done
In the morning.
That's right, because delayed adolescence, those youngins that fall asleep too late. Narcolepsy is diagnosed by,
In lab.
actually, all of the above. We didn't talk about the blood test, but there is an HLA-2 type test that they can do because there is a genetic component to narcolepsy. Trick question. Treatment for narcolepsy includes all of the above. That is correct.
And I remember what my question was.
Oh, good.
What is the differentiating factors to use an APAP versus a CPAP?
Oh, that's a good question. We use APAP through Somnia because we use home sleep testing, and so we don't know what level of PAP therapy they're going to need to normalize their breathing. And that's kind of the direction a lot of insurance companies are going to, is saying, let's just do a home sleep test and put you on the auto titrating. Because what the auto titrating device does is it senses resistance. And we'll talk a little bit more about this in follow-up care. But CPAP is a continuous positive airway pressure. So we set a number. We say it's set at 12 centimeters, and that's what pressure it blows at. You can ramp it up over a period of time so they can fall asleep at a lower pressure, but then it's set at that pressure. The pluses for the CPAP is it's usually figured out based on an in-lab test, and this is a pressure that works. So the good thing about that is you've got a set pressure, right? That should work because we've demonstrated it. The APAP is great because sometimes people are positional or sleep dependent and they're worse, and so the unit will sense that and will adjust the pressure when you turn onto your back if you need that, or if you go into REM sleep and you get worse. The drawback of that adjustment to the pressure is sometimes people are sensitive to those pressure changes and it wakes them up a little bit. So it's kind of you kind of have to figure out, do a cost-benefit analysis of which one's better. For a lot of people, if we just do a home sleep apnea test, it's great for just finding obstructive sleep apnea. You put them on the APAP and they'll figure it out. We have a guy we call him Patient Zero, who was severe, really, really bad. Like, I opened his study, I'm like, oh my God, this guy's bad. So we got him on APAP as soon as possible. He wears it every night. He's at the top of his range, but it's decreased his apnea-hypopnea index from over 75 to most nights under 5, because it's able to do that, which is awesome for him, and he'll tell everybody. I mean, he actually posted some on Facebook that said for people who can't afford the $99 to do that, his company will pay $50 of it so they can get tested. I'm like, dude, you are awesome.